infectious disease physician. And today we are going to discuss about atrial fibrillation in septic shock, which is a very tricky topic. And it is my pleasure to invite our speaker, Dr. Ram Manohar. He is a MD Internal Medicine and DM Cardiology, NAIMS, New Delhi. Right now, he's working as a consultant interventional radiology in Aster Ramesh Hospitals, Vijayawada. I also invite our moderator, Dr. Ganesh Paramasivam. He is a professor, head of the unit in the Department of Cardiology in KMC Manipal. So over to you, sir. The session initially, Dr. Ganesh will introduce us to the topic. That will be followed by the presentation by Dr. Ram Manohar. And at the end, we will have a discussion. Thank you. Over to you, Dr. Ganesh. Yeah.
Yeah, thank you, Praveen, for that wonderful introduction and bringing us this session. I welcome Dr. Ram also. Yeah, today's topic is a very nice one, very well chosen, typically interdisciplinary problem. So atrial fibrillation when in sepsis and septic shock. So typically atrial fibrillation, you think that it is a specific cardiac problem. Actually, it's not. So it's more reflective of a systemic issue in many of the cases. And there are many secondary causes for atrial fibrillation. And the common confusions that come up when we have atrial fibrillation is, we have this very high heart rate. What do we do? How do we control that? And second is the BP is low. What do we do? Do we shock? Do we not shock? Because typically the teaching is that if any arrhythmia, tachyarrhythmias are associated with hypotension and shock, you have to give a electrical shock to revert it. So that's a common understanding. But then what do we do when there is another, etiology in the middle which can produce hypotension and shock? So do we give an electric shock to revert this or not? So this is something which is a very common confusion. So this is about rate control and recovering the BP and hemodynamics. But then we know that atrial fibrillation is associated with stroke, a higher risk of stroke. Even a small run of atrial fibrillation can be associated with stroke. So do we anticoagulate them? What about septic, the underlying sepsis and coagulopathies and stuff? What are the medicines that we can give these patients safely? Because if there is hypotension, of course, beta blocker becomes contraindicated. Do we use any antiarrhythmics? Or what kind of rate is acceptable? What inotropes do we use? There's hundreds of questions that come up when we manage atrial fibrillation in the setting of sepsis and septic shock. And I welcome our speaker to take us through this presentation. Over to you, Dr. Ram.
Thank you, sir. Also, at the outset, I would like to thank Dr. Praveen and his team for the opportunity. So, as sir has rightly summarized, it's a very complex area, and much of the data, though cardiology is in abundance with the data, this is one area where we don't have data actually. So, I'll try to go through whatever data is available, and we'll try to come to reasonable conclusions at the end of the presentation. So, new onset atrial fibrillation occurs in sepsis and septic shock is a common thing. In sepsis, if you see the pooled prevalence across all the studies, it is in the tune of 10%, accurate being 13.5. And as per the older definitions where we used to call severe sepsis, the median incidence was in the range of 4 to 23%. When we see about septic shock patients, the incidence goes in 1 in 4 of the patients who have septic shock. The incidence is around 23%. And if you really do continuous 7-day monitoring, the incidence is much, much higher. Almost 1 in 2 patients in ICU with septic shock do develop atrial fibrillation, whether it be a brief one or a persistent one. I just try to go through a case and we'll discuss this at the end. So we have a 60-year-old woman who is a diabetic CKD admitted with abdominal pain. She developed new onset atrial fibrillation. Heart rate was in her 160s. And dilsum was given initially with a normal LV function. Then heart rate came down, but later on PP started dropping as the dilsum infusion continued. And now she also has free air under the diaphragm, and she needs to be operated for a perforated colon. How do we go about her rate and rhythm control and regarding anticoagulation? We'll discuss it at the end. So just for the non-cardiologists, this is how the heart fibrillates. This is a on-table fibrillating left atrial appendage. This is how fast the atrium fibrillates. So you can see that there is no time for filling of the heart. when Dr. Praveen has given me the topic, the clinical questions which came to my mind as aptly summarized by Dr. Ganesh is new onset atrial fibrillation an organ dysfunction of sepsis, or is it just a bystander? What are the short-term ramifications of atrial fibrillation during sepsis? Are different AF management strategies during sepsis are associated with different outcomes? And whether recognizing atrial fibrillation during the time of sepsis helps in long-term management and the change of prognosis. And as was the topic was given, I was also asking a few of my colleagues and even Dr. Praveen as well. And these were some of the questions which they have also raised. So I'll try to answer a few of them. Most of them don't have a proper answer, but I'll try to discuss as much as possible. So the first question, is sepsis associated with new onset AF? Obviously, we have seen the incidences. It's a resounding yes. Yes, sepsis is associated with new onset AF. And accounting for the age and cardiovascular comorbidities, sepsis is also associated with 7-fold increase in risk of new onset AF versus non-sepsis hospitalizations. And this is not a benign entity, and this has been shown to be associated with the short-term and long-term ramifications as well. But why does it happen? We know atrial fibrillation can be because of structural remodeling or electrical remodeling, and the traditional CHADWAS risk factors as a causative of AF, we all know, like age, diabetes, congestive heart failure, other contributing factors like other organ dysfunctions, etc. But when you have a patient who has critical illness,
Dr. Ram,
what
some audio
happens
issues.
is the same structural and electrical model at a rapid pace. This is being initial itself, or because of proximity. I'll try to turn off the camera, so just see if it is clear. Now, is it audible?
Yeah, sounds better. Yes. Now it's not audible again.
Now, is it audible, sir?
Yes, it's audible now.
It's clear. Yeah, I'll turn off the camera. Just let me know if you face again an issue.
All right.
So, where did I miss? Otherwise, I'll start from this slide itself. So, why AF during sepsis? We all know the CHADWAS traditional risk factors which can cause atrial. But when it comes to sepsis, additional factors also play a role, like inflammation with the sepsis itself, or catecholaminergic surge, which happens because of the inotropes which we give, or because of the sepsis process. And also it causes an autonomic imbalance where the sympathetic surge increases and the parasympathetic goes down. And also sepsis, because of the infection or any other cause, might directly cause myocardial injury and injure the myocytes, which can also result in atrial fibrillation or structural remodeling. And the other associated abnormalities like electrolyte imbalances and fluid shifts can also result in atrial fibrillation. So, as I was mentioning previously, new AF during sepsis is associated with both increase in short-term and long-term mortality. But one thing which I want to show through this chart is when you see these patients who have new onset atrial fibrillation in the black bar, the risk of mortality actually is equal to those patients who have +1 organ dysfunction. Say, for suppose who has just sepsis, but other patient who has sepsis with AK. So atrial fibrillation confers a risk which is almost equivalent to those of having an additional organ dysfunction. So when you go through the SOFA score, you can see the variables which are part of SOFA score, like respiratory, cardiovascular, liver, renal, coagulation abnormalities, and neurological abnormalities. One thing I just want to highlight in this SOFA score is all these parameters or organ system dysfunctions are in terms of the parameters of that organ dysfunction, except for cardiovascular system. Here, the SOFA score of cardiovascular system dysfunction is shown by how we are treating it with, like the inotropes. Nowhere else are the parameters how you are treating are taken into consideration. So is it a time that a specific organ dysfunction be a parameter of cardiovascular dysfunction? Can AF be one of them? Probably yes, probably no. We don't have much of a data yet, but But there have been papers which say that, as I've shown in the previous chart also, having AF is equivalent to as much as having an organ system dysfunction equivalent to any other organ. So probably with much more data, we might be able to say whether AF itself can be taken as a parameter. For that matter, any tachyarrhythmia can be taken as a parameter of organ dysfunction in the case of SOFA score. So how does AF problems cause problems during critical illness? We all know that there will be loss of atrial kick or the atrial systole during AF, which results in low cardiac output. And this results in systemic hypotension. And it was seen if a patient is having normotension, 1/3 of these patients do develop hemodynamic instability within 2 hours of onset if the patient develops AF with a fast ventricular response. It might be associated with new MI, which can be type 2 MI, or congestive heart failure because of AF. And the atrial stasis, which happens, also can result in thrombus formation and arterial thromboembolism. And it was seen that 2% of these patients can develop a stroke during sepsis hospitalization. So now we'll go into the treatment part, which is the important part of our discussion. This ABC pathway has been given by European Society, but the problem is not everything can be applicable to those patients with sepsis. So I'll try to speak one by one. Let's try to understand how a patient with AF in sepsis is slightly different from those patients who are non-septic. So the treatment of atrial fibrillation obviously would include treatment of atrial fibrillation itself, but also the most important thing is to treat the sepsis and the other metabolic derangements because associated with it. I'll try to speak about a few points about the metabolic derangements. So traditionally or classical teaching has been that before you start drug therapy for any sort of tachyarrhythmia, just see that if there are any reversible causes and try to treat them until and unless obviously the patient is hemodynamically unstable. So the same applies for atrial fibrillation also. Try to treat the electrolyte imbalances, acidosis, hypoxia. A few points which are often missed are most of these patients might be on beta agonists at a higher doses, which might also trigger atrial ectopics and finally resulting in atrial fibrillation. Myocardial ischemia is also a underappreciated entity in ICU patients with sepsis. Hypovolemia, anemia, infection itself, and pain and agitation can also lead to tachyarrhythmias and AF in certain cases. But one thing, as I was going through this topic, I was just thinking whether this traditional teaching that before you start drug therapy for these patients, you should really treat electrolyte and acidosis or not. But I was, as I've seen the data, it did not actually really help clarifying my doubt. But the available data says that in patient who is acidotic versus those who are non-acidotic, the prevalence of atrial fibrillation actually remained the same. And in one of the retrospective analysis and the systematic review, metabolic acidosis, electrolyte abnormalities, anemia, and thyroid dysfunction were not actually clearly associated with atrial fibrillation in patients with sepsis and AF. Thus, correcting metabolic acidosis alone is unlikely to prevent atrial fibrillation, or for that matter, totally reverse it. Management should focus on areas like treating the septic shock, improving the perfusion, and correcting the derangements globally. Obviously, the aim of treating acidosis would be to maintain a pH above 7.2, just like any other patient of sepsis, rather than trying to normalize the pH to solely suppress the apnea. So the same has been summarized here. So what I understood and what the best practice would be of the traditional teaching of reversing the reversible causes of AF should hold true as a best practice, since though the data which I've discussed previously doesn't solely support it, but they're all retrospective, and there might be many confounders which might say else. The other points which I want to just speak about a part of best practice in ICU would be to maintain a potassium above 4. Recently, the ongoing European Society of Cardiology conference is happening now in Madrid, where though not totally related to atrial fibrillation, but it was shown that in patients with heart failure, when you maintain potassium above 4.5, it was shown to decrease the incidence of any tachyarrhythmia in the follow-up. I I presume that the same would apply for any of the patients and try to maintain the potassium level above 4 or 4.5. And also, as I was mentioning previously, try to avoid coarrhythmic drugs. Beta agonists being a common one, and also other stimulants might be there. And other two important things I just wanted to highlight is regarding pulmonary embolism. We have seen incidences where a patient of sepsis is in ICU for some unrelated cause and develops new-onset atrial fibrillation. And on detailed probing, these patients, some of them, not all of them, a minority fraction, but a significant proportion, had pulmonary embolism, which might be a trigger for atrial fibrillation in this population. Similarly, a cardiac trigger, as I mentioned previously, a highly underappreciated entity is myocardial ischemia as a cause of atrial fibrillation. So, if there is clinical suspicion, I would not suggest that everyone do get a troponin done, but if there is clinical suspicion, check for serial troponins to rule out whether myocardial ischemia is a trigger for atrial fibrillation. And the third thing, which was classically described, though the incidence of right heart catheterization during the septic shock has come down, Swan-Ganz catheterization or right heart catheterization, putting a right heart catheter, has also been found to be significantly associated with atrial fibrillation in sepsis population. Now, going on to the actual question, rate control of a patient who has atrial fibrillation with fast ventricular rate and septic shock. As we go through the practice patterns, much of the data is from the West. We don't have much data from India. But as you go through the practice patterns, patient who has sepsis and atrial fibrillation in US, it was shown that the most common rate control agent which was used was calcium channel blockers. A disclaimer to say here is these patients were not all septic shock populations, but in general sepsis, calcium channel blockers and beta blockers were the predominantly used ones, digoxin and amiodarone being minority. But if you really think about it, in India, majority of us actually do use amiodarone a lot in patients who develop new-onset atrial fibrillation in sepsis patients, especially those with shock or with those with borderline hemodynamics. So whether our practice or our general understanding in our patients, does it hold true as per evidence or not? Let's discuss. So what is, I'll be slightly biased towards beta blockers in the usage of control of rate control in atrial fibrillation, since being a cardiologist. So I'd probably be more biased, but we'll take that with a pinch of salt. So electrical cardioversion and antiarrhythmic drugs have largely been shown to be ineffective in a patient with atrial fibrillation and sepsis. The reason being, these patients actually have had higher rate of recurrence. And one of the postulated hypotheses being, already these patients have a higher sympathetic tone, and by cardioverting or giving drugs which might increase the sympathetic surge, you're actually creating a nidus for recurrence of atrial fibrillation. Also, many of these patients are on catecholamines, norepinephrine or epinephrine. So it makes physiological sense that you give a beta blocker and curtail the sympathetic surge, which might help you in decreasing the incidence of AF as well as controlling the rate in case of AF. Obviously, it was also the obvious fact would be the patient has low BP. So whether this beta blocker would decrease the blood pressure is our main concern. The physiological hypothesis for all the studies, which I'll be discussing later, is that when you're giving a beta-1 selective blocker, it shows that when you give an inotrope, you're actually curtailing the selective beta-1 action, and you're allowing alpha-1 action to continue. So the estimated BP drop might not be so big in this population is what is estimated. Once we go through the data again, hospitals that have used more beta blockers for AF during sepsis had shown a better outcomes when compared to those who have used calcium channel blockers, digoxin, or amiodarone. So, beta blocker in sepsis, the physiological hypothesis of this came from this study where the practice patterns were seen. After this, a few studies have also come where they have seen whether giving beta blockers in patients with septic shock did help or not. One thing I just want to mention here is there is no RCT till date for patients who have atrial AF with fast ventricular rate and septic shock. Whatever one or two studies I'm discussing now I'll be discussing those patients who had tachyarrhythmia, not AF, tachyarrhythmia, which had a minor proportion of patients who had atrial fibrillation. So in this study, you can see that the esmolol was used to maintain a heart rate between 80 to 95 over 96 hours period. And then the rate of achieving the target heart rate was compared. And as a part of secondary outcome, mortality rates and the use of inotropic requirements were seen. So as you can see, in the esmolol group, contrary to what we believe, actually the norepinephrine dose has been lesser than those with the control group, though this is not again statistically significant. But when you see the other parameters also, heart rate, mean arterial pressure, stroke volume index, and cardiac index are as expected, that the heart rate has come down. And as you can see, the mortality also in the esmolol group at 28 days, the mortality was less. So, but you can see the numbers here. In the esmolol group, the mortality was around 50% when compared to 80%. Such a huge reduction in mortality with beta blocker alone is questionable. And again, this study is a small sample size, but probably only one of the few RCTs available in this area. Again, this is one more RCT where landiolol, which is again an ultra short acting beta blocker, has been tried. And again, it was shown that the incidence of nuanced arrhythmias were lower in the landiolol group. And with respect to the blood pressure, there was no significant drop of blood pressure in the landiolol group when compared to the control. So these were the meta-analysis of all the studies, which also have shown that using a beta blocker is relatively safe in persistent tachycardia population, where the minority were AF patients. So this is what the available evidence with respect to beta blockers is. And with this, I'll just move on to the area where we can discuss whether beta blockers, calcium channel blockers, digoxin, and amiodarone as rate control agents, which one is preferred and what is the available retrospective evidence we have. So as you can, what does the guideline say? Again, this is European Society guideline, not pertaining to AF population, but it says a patient who develops nuanced AF, you give either beta blocker or calcium channel blocker in a patient who has EF more than 40%, and you might give beta blocker or digoxin as a rate control measure in those with EF less than 40%. But when I've gone through the data regarding critically ill patients where the role of beta blocker was seen, it says the CRT consensus, which is an Italian group where they have defined the role of beta blocker drugs in critically ill patients. They mention beta blockers being the drug of choice in critically ill patients, but the beta blocker should be a rapidly acting and a clearing one, either esmolol or landiolol. So, and if you go about the other choices, like say amiodarone or calcium channel blocker or digoxin as a choice for rate control, again, a retrospective analysis of choice of one over the other has shown that beta blockers achieve the fastest rate control. Amiodarone is slower than beta blocker, but the efficacy of rate control at the end of 6 hours is similar to that of beta blocker. Calcium channel blockers do have a moderate rate control early, but it has been shown that they overshoot at the end of 6 hours. Digoxin, as we all know, has the slowest onset of action, and probably digoxin is inadequate in conditions where there is high catecholamine surge, like in sepsis. So probably when you see the choices also, beta blockers, amiodarone would stay as a better choice when it comes to septic shock population. And calcium channel blockers obviously would be contraindicated in this group. And digoxin can be a resort in addition to the above two drugs of beta blocker and amiodarone. When we see IV beta blockers versus amiodarone, again, this is one of the few recently done studies where retrospective large data has been collected, and those patients who received beta blocker and amiodarone in septic shock patients were seen. Beta blockers again have shown to be associated with lower in-hospital mortality, but amiodarone had significantly shorter duration of atrial fibrillation. And as I mentioned previously, blockers and digoxin might be indicated when beta blockers and amiodarone cannot be used. Again, things have become more confusing at the end, but what I would conclude is beta blockers, if tolerable and not the patient is not in worsening shock or in profound septic shock, beta blockers, especially the short-acting ones, might be a better choice than amiodarone, and we might probably try to change our practice of use of amiodarone for every case. And with respect to cardioversion also, do we really need to cardiovert all these patients and bring them into sinus rhythm? The answer is probably no. You reserve rhythm control only for those patients who have persistent symptoms, who persist to have heart failure despite rate control, or who have hemodynamic compromise despite adequate rate control. One thing to note here is, unlike other atrial fibrillation population, unlike other paroxysmal atrial fibrillation population, a patient who has nuanced atrial fibrillation in sepsis has a poor rate of success with electrical cardioversion. The rate of sustained sinus rhythm response is in the tune of 25 to 30% only, and approximately 70% of these patients do again convert back to atrial fibrillation. Also, one point to note as a best practice would be to avoid repeat shocks in case of septic shock. Try to optimize other therapies of sepsis and try to start amiodarone if needed, and then try to cardiovert the patient where the rate of success has been shown to be higher. One of the questions which was raised when discussing this topic was whether electrically cardioverting these patients do have risk of bradyarrhythmia or risk of asystole. As I was mentioning previously, reserve cardioversion only those patients with severe hemodynamic instability, and there is a minor risk of bradyarrhythmia post cardioversion. In the Finnish cardioversion study, it was shown that it was in the tune of 0.9%, but asystole as a response to atrial fibrillation is much, much lower, though we don't have data, but the risk is much lower. And according to the clinical situation, if the patient is really worsening, probably electrically cardioverting the patient might make sense, and the risk of asystole being very insignificant might not be a major concern. And with respect to the anticoagulation, again, I'm going back to the US study where a propensity matched cohort study was done, and it was seen whether giving anticoagulation to these patients of AF do help or not, irrespective of the CHADVAS score. Say if the patient has CHADVAS score of 5, but the patient has septic shock, it doesn't make sense that you anticoagulate the patient in therapeutic doses. Yes, you do anticoagulate because you need to give DVT prophylaxis, but it was shown that therapeutic anticoagulation in these patients of septic shock increases the rate of bleeding when compared to those patients who are protected from stroke. So even the guidelines, the SARTI guidelines, the Italian guidelines also do mention that you avoid therapeutic anticoagulation in patients with septic shock until and unless you have an obvious evidence. Like
I think Dr. Ram got disconnected.
Sir, is it audible now?
Yes. No, you are back.
It's from this slide only, sir, or did I miss it the previous slide also?
Yeah, this slide
from
only.
this slide only.
This slide only. So even the guidelines do mention that in a patient who has developed new onset atrial fibrillation with sepsis, wait till the patient improves, assess the CHADVAS score. If the CHADVAS score is 2 or above, then do anticoagulate the patient. But if the deteriorating, or if the patient just develops new onset atrial fibrillation, just continue with prophylactic anticoagulation and do not give therapeutic doses of anticoagulation. But few exceptions do exist, like if you really see a left atrial appendage clot or a left atrial clot, or the patient develops stroke on atrial fibrillation in sepsis, then you might need to anticoagulate this patient therapeutically. So this is what I was mentioning. So sepsis-induced AF increases the stroke risk. There is no doubt about it. But anticoagulation did not show clear benefit. CHADVAS score, as I was mentioning, is not a very good predictor of stroke in these patient population. CHADVAS score was validated for those patients who have AF, and the long-term outcomes, say 1 year, 2 year outcomes were seen, and then the CHADVAS score has been validated. But in the short term, CHADVAS score as a predictor might be poor. So just based on CHADVAS score, do not anticoagulate the patient therapeutically. And as discussed, anticoagulation increases the bleeding risk without a significant reduced stroke rate. So just give prophylactic anticoagulation rather than therapeutic anticoagulation. And once the patient improves, evaluate these patients individually as per Chadwick score and bleeding risk. You might anticoagulate these patients as per recommendations after hemodynamic stabilization. With respect to direct oral anticoagulation, in patients of sepsis, we don't have any data. So heparin, the age-old heparin, might still be the drug of choice in this population. And with respect to where we have absolutely no evidence, and I'll just try to summarize with a single slide whether what would be the choice and what I do understand with respect to vasopressors and AF. With respect to the choice, a patient who develops sepsis and septic shock, norepinephrine still remains the first choice, but do watch for tachyarrhythmias. And if the patient does develop atrial fibrillation on norepinephrine, try to decrease the dose of norepinephrine and try to introduce vasopressin so that the catecholamine load is reduced and the AF risk is slightly reduced. And in certain special situations, phenylephrine has been shown that it reduces the rate of AF when it was used as a replacement to norepinephrine. But again, there are downsides to it where phenylephrine, because of peripheral vasoconstriction, has shown to increase the risk of distal ischemia and all. Absolutely try to avoid dopamine and epinephrine in these population unless there are very specific indications to do so. And with respect to the post-hospitalization outcomes, say if the patient is in sinus hospital and because of some sepsis, he developed nuanced atrial fibrillation and he remained in sinus rhythm at discharge. Does this patient really has long-term implications or not was seen? And it was shown, surprisingly, even it was a surprise to me, where it was shown that 40% of these patients who develops a single episode of AF during hospitalization would have recurrence in the next 1 year, subsequent 1 year. And these recurrences are not associated with subsequent, they are during the outpatient visits and when long-term and implantable loop recorders were put and seen in this population. So yes, if a patient in hospital develops AF, you need to check his Chadwick score and you need to anticoagulate these patients. If you feel that the bleeding risk is much higher, probably you need to monitor the patient by putting a Holter or a long-term recording like with ILR. And then if the patient develops atrial fibrillation, you need to anticoagulate them. AF without sepsis. And as I was going, it was shown in multiple pathological studies also. Sepsis actually scars the heart, and this becomes the arrhythmogenic substrate, which results in high recurrence of AF in the subsequent future, even in the absence of traditional risk factors. These similar fibrotic changes were seen in those patients who have had AF with sepsis also. So sepsis itself is a risk factor which can change your management long term also. There are multiple research gaps in this thing. As we were discussing, rate control, rhythm control were never clearly defined. The optimal rate targets are not defined. Whether beta blocker or amiodarone, which choice is better, has not been defined. Though with the retrospective evidence, we say that beta blockers are better, but these are not purely RCT evidence. And whether other choices of oral anticoagulation, since direct oral anticoagulation have come up in a big way recently, because those patients who are on NOACs have actually had a lower bleeding event. Whether this novel anticoagulation would help in sepsis-induced AF is largely unknown, and this remains a research field. And also, one more thing which I did not discuss previously was role of corticosteroid. You have 2 patients who had septic shock and 1 patient received corticosteroids. In the patients who received corticosteroids, the incidence of atrial fibrillation was much lower. So whether such a sort of immunomodulation or anti-inflammatory therapy can actually mitigate the atrial arrhythmogenesis is also not largely known. And also whether giving prophylactic beta blockers, say, or amiodarone or also magnesium as a strategy to prevent nuanced atrial fibrillation in a high-risk septic population also remains a research field. And also many predictive models are being developed now. Artificial intelligence is coming up in a big way. The monitors which we attach in the ICU might help us in predicting atrial fibrillation even before it develops. There have been studies which has shown that the future prediction of AF in patient with sepsis has been shown even 1 hour before the patient develops atrial fibrillation. Having said all this, what would I really do for a patient who develops nuanced atrial fibrillation during sepsis? I'll try to summarize in a slide. So based on very low, the disclaimer being that everything which I speak is based on low level of evidence. What I would personally do, I would assess, I would see whether there is a change of condition due to atrial fibrillation. Like if the patient is developing supraphysiological heart rates, if the patient is developing hypotension, whether the patient's hypotension is getting controlled by minimal inotropic requirement, or whether it is a profound shock, or whether the patient is developing new organ dysfunction or not. Of course, if it is immediately life-threatening, I would DC cardiovert. But with the fact in mind that it is only a temporary fix, and 70% of these patients do revert back, do recur again within a couple of hours. I'll also search for any modifiable factors. I'll see if I have had any infectious source, check for electrolyte abnormalities, maintain potassium above 4 or 4.5. I'll try to avoid any beta agonists. Try to see if I'm giving IV fluids much more than required, and if I'm causing any sort of atrial stretch, and try to fix all of them. And then after seeing all of these things, I'll see whether the patient actually is developing a non-physiological heart rate. If the patient is not in profound shock, having borderline blood pressure or a well-maintained blood pressure with minimal inotropic requirement, I'll give a trial of a short-acting or an ultra-short-acting beta blocker. Esmolol is the only one available in our country. Landiolol is only available in Japan. So esmolol at the low dose can be tried. The advantage being it can be quickly turned off if things go bad. I'll again reassess. If the above treatment is unsuccessful and AF is still affecting the stability of the patient, I will then consider amiodarone. Amiodarone with magnesium has also shown to be effective. If there are no contraindications to give magnesium, I'll also consider adding magnesium to amiodarone. And with respect to arterial thromboembolism prophylaxis, I would generally not anticoagulate these patients in a therapeutic dose, but consider once the patient is stable or nearing discharge, and also consider for long-term rhythm monitoring. As we have mentioned previously, 40 to 50% of these patients do recur in the next 1 year. So the conclusions being, atrial fibrillation during sepsis are because of n number of factors: inflammation, catecholamines, calcium dysregulation, or autonomic imbalance. Incidence and recurrence are extremely high. Risk stratification score by CHADVAS is not of much help. Certain scores like SAFE have been helpful in guiding early interventions. Rate control by beta blockers have been found to be better than other methods of treatment. Amiodarone and magnesium can be useful as an adjunct in a patient who has worsening shock. CCBs would be better avoided. Digoxin in certain scenarios might be helpful. Anticoagulation decision remains challenging due to the bleeding risk. Vasopressor choice, noradrenaline still remains the first choice. Vasopressin or phenylephrine might help in reducing the incidences, but with an increased risk of ischemic complications. And long-term recurrence because of atrial fibrillation demands ongoing monitoring and cardiology follow-up for these patients. And there remains a lot of research which needs to be done in these patients for a tailored therapy regarding novel anticoagulation, prophylactic strategies, and development. Thank you. We can discuss the cases once we have doubts. So I have made 3 or 4 case scenarios where we can discuss them.
Yeah, so before going to Q&A and the other cases, Dr. Ganesh, do you have any comments or anything else to add?
Sorry, I'm not able to hear. Is my voice audible?
Yeah, Manohar, you are audible.
Yes. Yeah, good evening. Good presentation. Of course, this topic is clearly not something which has been directly
Let me
researched.
join back just a second. All
right. So should I just wait for Dr. Ram for a minute, Praveen?
What did he say, sir?
He'll just disconnect and join back, he said.
It's okay, sir. You continue. So
I have joined.
Right.
I have joined back.
All right. Yeah, we are audible now?
Yes.
All right,
Yeah, sir,
great.
you are
Thank you,
audible.
Dr. Ram Manohar, for that wonderful presentation. So, of course, it's an area which is not does not have a lot of research, done directly in that particular topic, AF in septic shock, because of course it's a difficult sick population, and there are so many factors, and it is a very heterogeneous cohort. Anyway, but he has made some very important take-home points for us to act on. So we can clearly see two main worries or aspects of atrial fibrillation. One is the part where it increases the risk of stroke, that we well know with chronic atrial fibrillation or long-term atrial fibrillation or paroxysmal atrial fibrillation in non-sepsis settings, that you need anticoagulation, and definitely that helps. There is benefit more than risk of bleeding. That's very clearly established in non-sepsis setting. But in the sepsis setting, as he has mentioned, there is no clear advantage. The risk of stroke remains high, but then adding therapeutic anticoagulation does not actually add value to your treatment. It can increase the risk of bleeding. So you continue with prophylactic anticoagulation. So that's a very easily actable take-home point. So that's about it. But when it comes to management of atrial fibrillation, sepsis, and septic shock, because the other end, that is balancing the hemodynamics, is actually quite a challenging task. Why we face the situation is because of the heterogeneous population that we deal with. In general, these are patients who are older, who have multiple comorbidities. In general, you rarely see atrial fibrillation new onset in a young patient with sepsis and septic shock. It's not as common. Usually, you see it in older patients. That's one important thing, because whatever said and done, whatever groups, age still remains as a single most biggest risk factor for atrial fibrillation. So given that, so the therapy with respect to managing hemodynamics and heart rate has to be highly individualized, because there are two things which are causing the hemodynamic impairment in these patients: sepsis with its inflammatory cascade, leading to a lot of vasodilation, distribution, and shock, whereas atrial fibrillation itself suppresses the cardiac output because of loss of the atrial kick, like Dr. Brahm mentioned. But how do you identify a particular patient in which is contributing more? So there is no simple rule of thumb or any algorithm that you can easily identify which component is more. It needs a thorough assessment. We also need a good assessment of how bad is the sepsis, in a sense, like how much of the inflammatory cascade, what stage of the sepsis is that particular patient in, is something to be taken in consideration. Similarly, atrial fibrillation, at what rates can it actually produce the hemodynamic disturbance that we are thinking about? So if it is a supraphysiologic, what he is mentioning is because the term needs to be understood in the sense that you expect certain amount of tachycardia in patients with shock due to other reasons, be it hypovolemic or septic. So if you see tachycardia and you see atrial fibrillation rate above 100, doesn't actually mean that atrial fibrillation is per se producing the shock, even if the rate is 120, 130. Many times we do not act if the rate is around hovering around 120, 130, because we consider that as a compensatory mechanism for other causes of shock. So when it goes beyond that 160s, 180s, 200s, then we are forced to act, and then that's when the drug choices come in. And he rightly pointed out that most of the choices have to be considered in the overall setting, and the only one which has some evidence is a very short-acting beta blocker. Now, one of the things that can be studied is actually whether we can check whether a patient responds to a short-acting beta blocker given under direct supervision. When we are monitoring him, give a short-acting beta blocker and do it. I mean, this is not from any guideline recommendation. This is a research direction. So let me clarify that. So that possibly some study that I would look forward to, or possibly do it ourselves. Check with esmolol whether there is some response, right? Whether this rate control is giving an hemodynamic advantage to patient who's in sepsis and septic shock. So Yeah, the rest of the points he is very well summarized. The long-term outcomes he mentioned that sepsis, atrial fibrillation, patient recovers, goes home. You can't forget it. You need to follow it up, assess the long-term risk of stroke, because there are some irreversible changes that can go on in the atria. So with that, I think we will go on to the cases. Maybe certain points we can take it up as we discuss the cases. Unless there are
Yes.
any Q&As we can take up now.
Yeah, I think we can go ahead with cases. Yeah.
So again, there is no one right answer for these things. Just we'll try to discuss what would be the strategy for each one of us. So 68-year-old male with community-acquired pneumonia and septic shock requiring noradrenaline requirement of 0.2. He develops nuanced AF with rapid ventricular response with a heart rate of 150 and blood pressure of 80/50. Lactate goes up to 4. Left ventricular dysfunction is not there, and he remains ventilated and sedated. What would be the initial treatment choice for this patient? Sir, how shall we go about it? Let us discuss about it, or what do you
Yeah, we will just discuss. We'll not put a question.
Yeah.
Yeah.
So, what do you think would be the appropriate right choice for this patient?
So now that you have taught us about new onset atrial fibrillation, probably the NORAD dose is not quite high. It is 0.2 mics per kg. If it is crossing 0.3 mics per kg per minute anyway, the patient is for hydrocot and probably a second pressor. If you are not thinking that patient is dehydrated or there is some reversible cause like catheter irritating atria, this atrial fibrillation, if you want to try, probably we start on a beta blocker.
Sir, I don't know. See, if say this patient has BP of 80/50 despite fluid resuscitation and everything, and if this rapid ventricular response is the thing responsible for it, I would probably not give beta blocker for this patient. I think 80/50, giving a beta blocker, he would definitely. I don't think this hypotension has been corrected. Since whatever studies, small studies or whatever studies were done previously, they're all like the patient has become stable. He comes under the definition of septic shock, but his BP has improved. He's maintaining MAP now well, and there is no evidence of any end organ dysfunction. Like this patient also has lactates elevated. I probably might not give beta blocker for this patient. What do others say, or Sir Dr. Ganesh say?
Yeah. So this patient, with like Praveen said, with a low to moderate requirement of norepinephrine, and with a rate of around 150, which is little above, what you'd expect as a response to hypotension alone. I would probably try, at least if it's new onset atrial fibrillation, I would probably try one electrical shock. Before that, I would confirm that the LA size is okay. You've already mentioned that LV function is normal. I would probably also check whether there are structural abnormalities or not. If there are no cardiac, the structurally heart is normal, and I would probably try at least one cardioversion in him, because in this set of patient is when we expect that if at all atrial fibrillation is contributing to the shock, and we can revert and keep it in sinus rhythm, they can actually, BP can improve. But like you already mentioned in your presentation, repeatedly trying shock in this patient, if he shows that he's not, he's reverting back into atrial fibrillation, would not be very useful.
Yeah, a few areas where I've gone through in some of the consensus, people also say that if you're trying to shock a patient of AF, and if you feel there is some sort of structural abnormality, say this patient is elderly and he has some LA size which is in the tune of 4.2, 4.5, and such patients have a much higher risk of recurrence. So people have also tried that if, since he's deteriorating, you shock him, but simultaneously also give him amiodarone. This has significantly shown to decrease the risk of recurrence in this population. Again, these are all just anecdotal things, but this is one thing which can be done, because most often than not, such type of patients actually recur again with AF in a couple of hours. So you'll have to do
Yes.
something so that he'll not go into AF again.
Yes, I
So
agree with you. As if the biggest predictor is, of course, the LA changes. If you have LA changes clearly visible on echo, such macro changes, then shock may be electrical shock may be futile. So it is better to go ahead with some kind of a rate control strategy. Again, in these populations where we think that where electrical shock is not going to help, they are also poor candidates for rhythm control strategy. So in these guys, I would go for rate control strategy. So as a part of rate control, the choices available with us are beta blockers, amiodarone, digoxin, and calcium channel blockers, of course. But in general, we do not use calcium channel blockers for this purpose. So beta blocker, you already mentioned that because already there is a hypotension with inotropic requirement. Possibly you do not try beta blocker in this patient. So you're left with choices like digoxin and amiodarone. If any doubt, like I mentioned, if everything is fine, it's worth trying electrical shock once. And if the patient doesn't maintain and goes back into AF, possibly I will not keep persisting on trying electrical shocks again and again. And of course, simultaneously, we have to start him on some kind of a rate control strategy. Amiodarone seems it's a very popular choice, but it has its own problems. So I would suggest, if possible, try and use magnesium and digoxin more often if it's feasible, and then go for amiodarone.
Sir, I just want to add a couple of points here.
Yes.
One, a commonly seen entity is hypotension because of amiodarone itself. One thing which is commonly done, a common mistake is give amiodarone over 15 minutes. Never ever give it as a bolus, especially with borderline hemodynamics. Amiodarone, one, it has a beta blocking property also. That's why it's causing rate control. Second important thing is it has solvents. It has solvents like polysorbate 80, which actually cause hypotension. When you give it slow, the risk or incidence of hypotension with IV amiodarone is much, much lower. So that needs to be kept in mind, because you give amiodarone for this population. Say for this, suppose you have chosen that you don't want to cardiovert this patient electrically and you want to give amiodarone. What happens generally in real world is this patient would receive amiodarone and it is given bolus or fast. This patient would develop much more hypotension and then the cycle starts. So it is always required to see that you give it slowly over 10 to 15 minutes, never give it as a bolus. Because such a borderline hypotensive patient would ultimately land up in arrest or something if you give a bolus of amiodarone.
Yes, that's a very important point. Often when we do choose amiodarone to treat these patients, 100 ml of amiodarone, 150 milligrams available as 100 ml infusion is available. It's better to start that, and it can't really go much faster than 10 or 15 minutes. So that would be a very important suggestion. Now, again, that point about electrical shock that we were debating, why would one choose? Like, you have to tick all the boxes before you try. One is, of course, have an LA size which is normal, macro LA dysfunction or NV dysfunction, grossly abnormal, structurally abnormal heart is all ruled out. Only then you consider electrical cardioversion in these patients. Otherwise, it's better to start with some medicines, especially with a heart rate of 150, which is something which will push you to treat. But then it does give you enough time to maybe try other therapies before you try electrical cardioversion. So it has to check all the boxes before you try electrical cardioversion.
So I want to just add, this is not an uncommon scenario where so basically the patient's BP is 80/50 with a heart rate of 150. If you look at the diastolic shock index is quite high. So it looks like the patient is very severely vasopressic despite of being started on NORAD. And the diastolic BP 50, which we are seeing at 150, is like falsely high because the heart rate is quite high. We are not giving enough time. So the actual diastolic BP will be much lower, where the coronary perfusion can be affected. So in this situation, I really want to have that diastolic BP at least a little bit higher than 50. But again, if you increase on pressors, the heart rate can further go higher, which can complicate. So probably at this point of time, we are seeing a little bit of vasoplasia. So I will make sure that patient is fluid resuscitated and probably add hydrocort upfront. But if the heart rate is still high, we have three options. So amiodarone beta blockers versus cardioverting the patient. So what do you think we should do? Like we kind of discussed all three we can do, but
Yeah.
what should be the
Uh,
ideal thing?
Right. Okay. If you want a clear situation where you would want to shock a patient, try shocking a patient with atrial fibrillation is if this guy comes in and the BP is okay, and then you clearly have association between initiation of atrial fibrillation and the onset of AF, which happens in hospital. That would be a great situation where you can try an electrical shock. So that's one situation of the way, and we do see many times that. Because we have continuous monitoring, do look for these points when what happens many of the times is you are called in only when hypertension has already happened. Somebody calls and then tells possibly that there is hypertension going on, especially in a ICU setting where continuous monitoring is not available. Do take the opportunity to go back and see the trace. Most of the monitors, I think, allow few hours of trace backs and see what is happening. Just relate the heart rate with the BP and see if there is a clear relationship between this rapid heart rate, ventricular response, and hypotension. If you can establish that, that gives you a clear reason to act, and the confidence that it will help in undoing the abnormal hemodynamics. So in the other situations, like Praveen said, it is not an easy call if you cannot clearly establish that it was fast heart rate, which has caused a drop in BP more than what it was earlier with sepsis alone. That's a difficult situation to handle, and there is clinical judgment needed as to which component is is actually contributing more. Only if you determine that atrial fibrillation, I cannot explain this with sepsis alone, because it's a small patch and the blood workup doesn't show that the inflammatory cascade is activated to a great extent. So if you have evidence something like that, and you attribute the hemodynamic derangement to largely atrial fibrillation, then it gives you a stronger impetus to act with either electrical cardioversion or use upfront therapies like amiodarone straight away.
Yeah, true, sir. Probably at the end of the day, for such a patient, trend matters. How the patient's heart rate and BP is responding. Uh, Obviously, the decision, since this is a screenshot of it at a certain time point, probably the previous lactate was the lactate now, the previous blood pressure was the blood pressure now, or the previous heart rate. If the patient is 130, 140 heart rate in sinus rhythm was very fine, and the heart rate has jumped just 10, but the pressure has dropped by 30, 40, then it probably is because of atrial fibrillation. So those things, the trends which do happen matter. I don't think a single value. See, this sort of MCQ question doesn't matter. In real world, probably the trend is what that matters. And how the BP has dropped with the increase in heart rate also matters.
So basically, we are trying to discuss about possible, like in this case, most likely the low BP is probably contributed both by sepsis as well as AF. Even the heart rate is 150, it is not like 170 or 180. So it is both are contributing in this patient. So I am really not worried about the patient's reversal of atrial fibrillation. So if I have to choose like amiodarone beta blocker, now that there is some evidence of beta blockers with mortality benefit in septic shock patients, so should I be preferring beta blockers because they're again short acting? You can be
Sir,
yeah.
what if you don't want to cardiovert this patient, or if the patient says I don't want to get electrical cardioversion? So
Yeah.
in that case, what I would do is I would probably just see with fluid boluses how it is responding. One. Second thing,
Yeah.
probably slightly, as the norepinephrine dose is not very high, I'll slightly increase the dose. Or again, not with the good evidence, people have tried adding vasopressin, low dose vasopressin, and see if the BP increases or not. And once the patient achieves a reasonable blood pressure and the lactate start coming down, then I'll start adding beta blocker. Not at this scenario, not at 80-50, I would not probably.
Okay, so I wanted to ask one more question. Like in critically ill patients, they require some amount of sedation. So we commonly use Dexmed, and it is shown to decrease the at least new onset atrial fibrillation in septic patients. So if we need to sedate, can we use Dexmed in this case, or because again there is some arrhythmia, you don't want to use it upfront? Is it a contraindication like presence of AF to use Dexmed because
No,
it
sir.
will bring down the
No,
heart
sir.
rate?
No. I don't think so. It is not a contraindication to use it. You can use it, as you were mentioning. Certain drugs like Dexmed, or in that sense, any sedation has actually decreases sympathetic surge and decreases the rates, whether it is be sinus tachycardia or incidence of new onset tachyarrhythmias and corticosteroids. I think these two are the things where there is some evidence, some sort of solid evidence that the tachyarrhythmias are slightly less.
Yeah.
But won't Dexmed cause more hypotension?
So the Dexmed will actually cause
As
decrease in heart rate, sir. But here heart rate is anyway not helping us. It doesn't cause
All right.
vasopressia.
it doesn't cause
Yeah, I mean,
significant hypotension.
like, okay, so not much data on Dexmed and atrial fibrillation also. In some studies, actually, it has shown that it can increase atrial fibrillation. Of course, in some situations, also have reported that AF has reduced. So it's a mixed bag. So again, like I said, for many of these nuanced situations, especially in critically ill patients, there's a lot of data that is lacking. We actually have to use a lot of clinical judgment in treating these patients with just some general guidelines, many of which has been discussed today.
Yeah.
And also, I feel one probably a controversial thing, but I think sometimes what happens is a proper communication between the critical care or the infectious disease team and cardiologist is also what is needed. Most often, what happens is we get a call and we speak on phone and decide. Not totally related to our theoretical part, but this is what happens in the real world also. I think a heart team approach, which is being developed, team approach for many things. I think cardiologist being a part of critical care team is also a important aspect here. Both give and take is what is needed in these scenarios. Because see, we are discussing this case for such a long time, but I think when such a call comes to us, the decision is made in a minute. And I don't think that is actually right, but that's what is being done.
So how we look into a patient with septic shock is if the patient is having vasopressia with a high diastolic shock index, and once you are increasing the dose of NORAD, if BP is not improving and heart rate is worsening further, then we think that NORAD, there is some peripheral vascular resistance to NORAD. So further increase in NORAD will only harm. Even in this patient, it is good that we have written the NORAD dose of 0.2 mics per kg per minute, but in reality it's like 3 ml, 4 ml. We don't know what patient is getting. So the threshold right now, whatever guidelines are there to start steroids or vasopressin is more than 0.3 mics per kg per minute, but that is the point where the mortality of septic shock goes above 40-50%. Yeah. And I wanted to ask again one more question. Many of the times we see the new onset atrial fibrillation in the patient, and that reverts back to sinus after a day or two. So what to do with this anticoagulation? Should we give anticoagulation eventually, or because it is reverted, we can just leave
Yeah,
it?
that's what I was mentioning previously, right? So if a patient has, see, for short term, at least till stabilization, just give DVT prophylaxis, nothing to be done, except the patient develops stroke or he has an obvious thrombus in the atrium or atrial appendage. If such a thing is not there, just once the patient stabilizes, assess his risk factors, STADVAS score. If the patient has a risk score of 2 or above, these patients need to be anticoagulated. The chance of recurrence in the next 1 year is 40 to 50%, which is huge. So need to be anticoagulated.
One other thing was very intriguing, like the incidence is whatever data you have shown, Dr. Ram, it is quite high. Like you are saying that every third patient is developing atrial fibrillation.
I think see, that's what I was mentioning. Even telemonitoring, very brief episodes of AF lasting a couple of seconds are very common. See, leave alone the septic population. If you really see into an elderly patient and just randomly do a holter for him, even such patients can have silent episodes of atrial fibrillation. So whether these episodes are really clinically relevant or not is questionable. Second thing, probably that is the reason why the stroke risk is not very high in this population also. So we don't know how much contribution is because of just monitoring these patients, because all these patients are in ICU and are under monitoring. Are we picking up these patients? But when it was seen in non-septic versus septic patients, it was shown that the incidence jumps up by 7 times. But whether all of this is clinically relevant or not is not clearly known. Yes, the values seem to be pretty high. And the demographic profile of these patients are also not clearly known. See, this is just pooled data from many ICUs across US, and their incidence of AF has been shown. Whether these patients are really much sicker or who are having higher traditional risk factors for AF, all these things are not very clearly known.
Yeah. Do you have more cases to show, Dr. Ram?
Yeah, I have. I think I have.
You have discussed almost. Okay.
One more case we'll just have. 56-year-old woman with UTI causing sepsis. She's on norepinephrine of 0.05. Develops nuanced AF with heart rate of 130. And BP is 105/60. She's awake and perfusion is adequate. Bedside echo is normal. Which strategy best achieves? See, this is straightforward. I think we had multiple discussions now. So this is the ideal case where you can give a beta blocker and see. Anything to any point of contention or anything to discuss in this?
No. So when we are starting beta blockers, what will be our target heart rate?
Yeah. See, again, in ICU patients, in general, multiple trials have shown a heart rate of 100 to 110 is enough. But on the contrary to what has been mentioned in these patients, but if you go through the trials which have shown on esmolol or landiolol, their target was to achieve a heart rate less than 95 is what they have done. But those patients are not purely AF population. There was a significant chunk of patients who had sinus tachycardia there. Their logic is you bring down the heart rate, you increase the diastolic filling time, you increase the LV preload, and then your BP also.
Yeah, makes sense. If there are any other questions, you can put it in chat box. Yeah, sir. Yeah, sorry.
No issues. So this is another patient possibly we may not do anything about. Maybe you can give some fluids, try to bring down the inotrope also. That's definitely a viable option. Again, like he mentioned in the previous case, it depends on the trend. Like, has this patient come on noradrenaline just recently and the heart rate is going up? Or is this patient being tapered off inotropes at present and this is the current slide? No, all this would actually matter. If it's a patient who is actually in the recovery or a plateau kind of a phase where you're thinking of weaning off inotropes at this heart rate, might as well just continue with your strategy. Just remove the inotropes. That itself will possibly bring down the rate much lower. Definitely not a case for electrical cardioversion. Anticoagulation strategy, same. Continue with prophylactic anticoagulation and decide regarding longer term anticoagulation for stroke based on Chatra score and other criteria like the LA size and all that. If the patient's BP has actually it's worsening and you are on the track of adding this norepinephrine newly, then you might think of the other measures that we discussed.
Yeah. Yeah, I think it is the same scenario. If the patient worsen further, you have to see whether she is worsening because of the sepsis which is worsening or whether it is AF which is contributing more. So there is one question from Dr. Mohan Sai. Do we have any way to check if beta blocker is going to benefit in a subset of septic patients? Just like a diuretic stress test, Furosemide stress test we do.
Yeah, so this is what I was mentioning.
Yeah.
So it looks like it's a good opportunity to conduct a research to find out whether you can pick out these patients who are worsening because of this sympathetic overdrive and rapid ventricular rate. maybe we can design a study wherein you can act by consider resmolol test or something to see what happens, and based on the response you take further action. So or at least conduct a trial where you can show that there are responders and non-responders at least, and then study the characteristics. So definitely a lot of opportunity for research in this particular area.
I think checking VTA will be a little difficult with irregular heart rhythm in these patients. So one question is like, can we give a small bolus and check VTA before and after?
It's difficult.
It will
What
be
happens is each beat might have a different VTA, so it
Yeah.
will be difficult. And so it is the overall way. If you give the beta blocker, see how the patient overall responds. A
Yeah.
single beat might be difficult. Even the average might be difficult there. See, people sometimes in echo, at least the rule is usually whenever you're taking such sort of gradients in a patient with AF, take an average of some 6 beats. But again, that also has its own flaws. If the 6 beats are fast and then it becomes slow, it is difficult to say. The overall trend is what that matters.
So if a high heart rate is contributing to drop in blood pressure, once we start decreasing it, probably we should see a trend of improvement in some blood pressure in the patient after starting esmolol, probably. And if it's dropping further, probably we have to stop there rather than escalating dose.
Perfect.
So what is the dose of esmolol we use commonly in this patient?
See, usually what the trials of these septic patients have done is they have given 30 mg bolus initially, which is 0.5 of the per kg of body weight, and then they have given 1/10 of the dose. Around 3 mg is what they have given as infusion. Many of these
Per-
trials which have shown the you're able to hear.
Yeah, no. Go ahead.
Yeah. So and they have put the patients on 3 mg per 3 mg infusions and increase the dose as per the response. Usually the initial response which we expect is 10 to 20% drop. And after the 10 to 20% drop, see how the BP is responding and other parameters are responding. If you feel that further drop in heart rate would improve his hemodynamics, increase the dose. No standard protocol seen, they have used different protocols. So I think it is reasonable to start with a low dose and try to increase the dose and then first. Since this is a very ultra short acting, okay, you give bolus, increase the dose and see. And while you are
Manohar, I think you got disconnected. Okay. So we'll conclude today. Thank you, Dr. Ram Manohar, for an excellent presentation, and thank you, Dr. Ganesh, for a good overview and your insights into the management of atrial fibrillation patients with septic shock. If there are no more questions, I think we can end the
thank you, Dr.
session.
Ganesh. Thank you, Dr. Ganesh.
Yeah. Okay.
Thank you, Dr. Ram. Thank you, Praveen.
Thank you, sir.
Thank you.